All right, this is a new format that we have now where we change every half hour. I think it's the generation X or Y that doesn't have that long of an attention span, so we have to keep changing topics quicker. We used to do these things for an hour in the past. We are going to talk about probably everybody's favorite case, acute urinary retention. There's not a doc in here who doesn't love an acute urinary retention case because of two things. One is the problem is obvious when they come there, so there's no diagnostic dilemma. And number two, it's one of those really feel-good cases. You put a catheter in, you decompress the person, the guy thinks you're the most wonderful physician in the world. It's just basically a nice case when it goes well. When you can't get the catheter in and it's a bloody mess and you've disrupted the urethra and stuff, that's a whole different matter. But when it goes well, it's one of the best cases we do. We're going to talk about a couple of articles about acute urinary retention. There's not a whole lot to talk about here, but there are some myths to talk about as well. It's interesting that the word catheter itself comes from the Greek. It means to let down. The first description of it was from 2600 BC, where they were using reeds from the Nile. They would thread them up through the urethra to decompress somebody who got urinary retention. Over the years, they've used leaves, straw, gold, silver, copper, brass, all kinds of different things have been put up there. In the 18th century, they developed a little curl at the end of it, the coude, that would make it easier to pass the catheter. And the original red rubber catheter, you'd think when that came out, that would be a big hit, because now you weren't putting something rigid up there, you're putting something smooth up there. But when they put the catheter up there, they would then suture it to the urethra. So it wasn't real popular. In 1927, a guy by the name of Frederick Foley developed the balloon, and the rest is history. Once you put the balloon on the end of that thing, everybody wanted one of them. So, I guess if you had the choice of we're going to put this thing up, blow a little balloon in there, we're going to suture it to your urethra, the old-fashioned way kind of fell out of favor very, very quickly. We do it a lot. It is, in the ranking of things, it is not one of the more painful things you can do. What's the most painful procedure you can do to somebody? Anybody know? Nasal gastric tube, exactly right. Every study that's looked at it where they take a bunch of people and do procedures to them, they all rate nasal gastric tubes as the worst. And Foley kind of falls down a little bit in kind of the middle of the pack. So it's not that bad. First article says, well, you know what, it may not be that bad, but you're not having it done. I mean, it's, how many times do we tell people it's almost over, it's not too bad because we're standing on the end that's pushing a tube somewhere. The people on the other end receiving the tube aren't too thrilled that it's not just over yet. But what they did is they looked at it and said, you know what, a Foley's not that painful of a procedure, but can we make it any better? And the first study said they took a bunch of women who were getting Foley catheters, gave them a visual analog scale, a 0 of 1 to 100, point to how bad this thing hurts, and they divided them. 50% of them got lidocaine mixed with the lubricant, and the other 50% got just plain lubricant. Put on 1 minute before, so it didn't get a whole lot of time to work, and then they all got a 16-gauge 16 French catheter put in there. What they found was the women that had the lidocaine placed rated the pain as being 22, and the people with the lubricant without the lidocaine rated it as being 25. So for someone who's got a short urethra, it doesn't seem to make that big of a difference. It's interesting that as they described them, younger women, which was women younger than 6 years of age, which I thought was a great cutoff, they said the pain was a little bit worse for those people than the women over 60 years of age. If you switch chromosomes and go over to the guys, it's a whole different story. From a guy's perspective, a Foley catheter is just kind of a little bit shy of an NG tube. 36 men, this is study number 2, lidocaine versus plain lubricant. Here they put the lubricant in ahead of time, so they gave them 15 minutes for the thing to work, and then they placed the Foley catheters. Big difference. Visual analog scale, 38 if you gave the person lidocaine, and 58 if you didn't give them lidocaine. So there's a big difference in terms of those two things. The other thing they noted that is if you put the lidocaine in, well, it's easier to pass the catheter. You were more likely to pass it on the first try, which would probably be true because we've all seen it where you're pushing the catheter in, the person's straining and squeezing, and what do we say? Just relax, Mr. Jones, this will be in a second. It's a lot easier to say that, but when they're not straining and squeezing, it seems the catheters will pass a little bit quicker. The other thing is, how many people have the Foley catheter kits that have the lubricant or whatever, it comes in a little squeeze thing that you can put the tip in the urethra? That makes a big difference. There's some kits where it's just a little surgical packet that you tear open and kind of squirt it on the sterile sheet there, and then you dip the Foley in it, and then try and path it. The others come with an actual little compressible syringe-like device that actually injects the lidocaine or the lubricant into the urethra. If you can, it's always better to inject it all the way up into the urethra. It does make it pass a lot easier. And what we do is if we get, whatever kit the hospital got the best deal on is the kit that we get, is if you get the one with just a little package, just take a small syringe and aspirate the stuff out of there and then squirt it into the urethra, because it does make it pass a whole lot easier. I will tell you that the urologists in their office routinely do cystoscopies this way as well. They'll inject the urethra with some lidocaine, and then they'll be able to do a cystoscopy on a male or female without any problems. The number 3 is an article on different types of catheters. Instead of a Foley catheter, what about a condom cath? And it's kind of interesting. They surveyed nurses and they surveyed patients, and they said, which would you prefer? Surprisingly, the patients, 54% preferred a condom catheter, 16% had no preference. When they surveyed the nurses, 40% preferred the condom catheters, and 16% had no preference, which is kind of strange. So if you think about it, condom catheters aren't the easiest things to work with, especially from a nursing perspective. Foley catheter, you put the thing in, you blow the balloon up. Unless they're really demented and yank the thing out, it's pretty much in there to stay. Condom catheters are kind of a pain in the neck. If you don't put the little elastic thing on tight enough, the things fall off. Put the elastic thing on too tight, something else falls off. So it's not the kind of thing that you'd think the nurses would want to deal with. We never use them in the emergency department. I don't think we've ever put a condom catheter on any patient in the emergency department. But yet I remember on the floors that the things were always falling off, and somebody was tripping on them, and somebody's grandson was playing it when they came to visit grandpop and stuff. So I'm surprised the nurses preferred it. That many nurses preferred the thing. All right. Supposing you get the guy who comes in with the big bladder. He's got this giant thing. Looks like he's about 6 months pregnant. You examine him. You percuss him. You decide to put a catheter in. You put the catheter in. Goes in, no problem. Now what do you do with them? How many people take and send the person home with a leg bag? Leave the Foley in, send them home with a leg bag. How many people yank this son of a gun out right after they finish decompressing the bladder and send them home without it? Not too many. Turns out you're probably right. Next 2 studies look at, can you pull the catheter out and send them home? First study looked at 60 males. It was immediate removal, removal after 1 day, removal after 2 days. So you had 3 arms to the study. They then judged successful treatment is if the person was able to void on their own after you removed the catheter. Success rate for those who pulled the catheter out immediately, so you decompress them in the emergency department and pull the catheter out, about 28%. So about a quarter of those people were able to void and go home. And one of the reasons that happens is if you look at the anatomy, as the bladder gets more and more distended, it actually doesn't move in this direction. It expands that way, but it also flips up anteriorly, and it actually kinks the urethra. And in those people, what will happen is, if it's not that they have BPH, they got urinary retention because they took a phenothiazine or Benadryl or something like that. In those people, if you just decompress that bladder, it flops back into position, they can void on their own. And that's why about 28% of these people were able to void spontaneously. Most of the people, though, have a bigger problem than that, and the problem is you stretch this bladder out, and now the detrusor muscle is just fatigued. It's just stretched out too much. And it has to be a certain size to be able to contract. And because of that, when you pull the catheter out, they just fill right back up. It's this big old floppy bladder now instead of a nice, tight muscular organ. If you took it out after 1 day, they actually did worse. Only about 20% of people could void spontaneously. But then if you took it out after 2 days, 36% of the people could void. One of the other findings that they had in the study was it did depend directly on the amount of urine in the bladder. If you drained more than 900 cc's, it was almost no shot that this person was going to void spontaneously, even after 2 days. These people needed a lot of time to get the muscle tone back in their bladders. If you drain less than 900 cc's, it seemed that those people had a much better chance of gaining spontaneous voiding within the 48-hour window. Number 5 is a single-arm study, same type of thing. Looked at leaving the Foley in for 2 days, and then looked at who needed to go to surgery, who needed a TURP, and who didn't. And what they found was, again, after 2 days, about 55% of people could void spontaneously, and about 45% of them couldn't void spontaneously and needed to go on to have a TURP done. From our perspective, from an emergency medicine perspective, for me the take-home message is, unless you have a burning reason to take the catheter out, just leave it in the patient, send them home with a leg bag, and let a urologist take it out at a later time. The next question says, well, you know what, supposing you put the catheter in, but you also give them a little bit of medical treatment as well. Suppose you put them on something like Flomax or one of those type agents to kind of loosen up the sphincter down there, an alpha blocker. Maybe these people will do a little bit better. Number 6 looks at 360-man urinary treatment, urinary retention treatment for BPH, benign prostatic hypertrophy. Half of them got treated with an alpha blocker, Uraxil, and the other was treated basically a placebo group. What they found was when they pulled the catheters out, the treatment group, 61% were able to void successfully compared to 47% of the control group. So what it says is when we put these catheters in, it might not be a bad idea to start the people on one of the treatments that you would start them on anyway if you found them before they got urinary retention. So suppose the person showed up in the emergency department and said, geez, I got hesitancy, urgency, I'm not emptying my bladder completely, getting up to go to the bathroom 3-4 times a night. Maybe if you saw that person, you say, oh, geez, I'm going to put you on some Flomax, see how you do. The other thing is, what they're saying is, well, if you had to put a catheter in them anyway because they had urinary retention, there's a good chance they have BPH. Go ahead and start them on the Flomax or, in this case, the Uraxatrol. And this way you'll be 2 days ahead of the game. When you do pull the catheter out, they'll work because all these agents take about 3-4 days before they really get the maximum effect. Just as an aside, how many people use Flomax for their renal colic patients, kidney? Yeah, it works very, very well. If you take the people with renal colic, there's some real good data now that if you put them on the Flomax, they will they pass the stones because it's a smooth muscle relaxant. Relaxes the ureter and they pass the stones a little bit better. It's always weird because do you get the phone call from the pharmacist that says, you wrote for Flomax and it's a female patient, what are you doing?
I haven't gotten it yet. I'm waiting for it.
Yeah, I mean, that's what I usually get. It's like, doc, did you put the wrong name on this prescription? It's like, no. But it does work, and it seems to be a little bit better. Number 6 is pretty much the same study as number 5, only this time they looked at did giving these people an alpha blocker decrease the need for TURPs, and it did as well. Guy comes in, big bladder, obvious urinary retention, put the Foley in. How many people throw the Foley in and just walk away? Unless the collection bag falls off the stretcher because it's so heavy you don't go back to the bedside. Yeah, how many people let a little bit out, then a little bit more out, and a little bit more out? How many heard you're supposed to do it that way? So it's a little stock cock on the end of it, just let a little bit of urine out. Anybody ever hear that theory? Yeah, I mean, if you read all the textbooks, that's exactly what they will tell you. You have to decompress the bladder slowly. Otherwise, bad things will happen. They'll get vasovagal, they'll get syncope. Well, it doesn't matter laying down. I mean, if you're putting Foleys in and people are standing up, your department's more crowded than mine. But, so if they get a little syncope, who cares? They'll get hypotensive. And the big thing they'll get if you decompress the bladder too quickly is hematuria. Because this bladder just scrunches down and they bleed. I have no idea the mechanism why they're supposed to bleed, but they do bleed. This is a real nice study, prospective study, 300 cases where they either rapidly decompress them or they slowly decompress the bladders. And guess what? They had about 16% hematuria. It was minimal at most, and 14% of these people, when they did cystoscopy on them, had a reason for the hematuria. Either had a small bladder tumor or something else going on in their bladder. So it turns out that slow decompression is not necessary in these people. Number 9 is a meta-analysis, again, looking at rapid versus progressive decompression of the bladder. Hematuria, 2 to 16% of the people. I think it's probably closer to 2%. My experiences have been that it's probably 2% of the people that get it. There was no clinically significant drop in blood pressure. Post-obstructive diuresis. How many people worry about that? You put a Foley catheter in, you decompress this thing, and now you're worried that the person's going to just continue to diurese. Yeah. And you see that all the time. But it has nothing to do with how quickly you decompress the bladder. It has to do with the fact that they've got some metabolic derangement and you've basically backed your urine all the way up to distend the kidneys, and they have to reestablish their salt gradients in their collecting tubules before they'll get the ability to concentrate urine. They're going to have a post-obstructive diuresis no matter how quickly you let down the bladder. Interestingly enough, if you are to do it correctly, you you are supposed to let out 50 cc's an hour. That means that the guy that shows up with a liter in their bladder, it's going to take, what, a day and a half to decompress them? You're not going to be real popular. But there are a bunch of nurses. We have any nurses here? Gotta have some nurses here. Nobody will admit to it? All right. The nurses, they surveyed a bunch of nurses, and they said, I always let it out gradually. I know, we were taught in nursing school, this is what we do. And they said, how do you do it? After 750 cc's, I clamp the Foley. Well, that's not exactly letting it out gradually. That's like letting almost all of it out and then getting back to the bedside and going, oh, holy shit, I got to clamp this thing. And then clamp the Foley on them. So they said 750 cc's was a good amount. Interesting question. And how many people, if you put a Foley catheter in a female patient, automatically follow it with an antibiotic? Anybody here? They raised that question in article number 10 because there is a subset of people who feel that urinary tract infections are very common in female patients, especially if you put a Foley catheter in them, and that you should prophylax them. Surveyed 300 healthcare professionals, and they asked them who routinely puts these people on antibiotic. And what they found was 20% of these people, 19% actually, always put a woman on a antibiotic if they put the catheter in them. And you think, that's ridiculous. About 41% of them say they do sometimes. I mean, and all of us do sometimes. If you get that person that's really difficult, they're flailing around, the Foley's fallen on the floor a couple times, somebody stepped on it, and you pick it back up and you finally get it in, yeah, those people you put some antibiotics on board. But by and large, that kind of real sweet, no problem at all, it goes in, no difficulty person, it doesn't make any sense to put those people in antibiotics, and you're probably going to cause more of a problem in the long run anyway with them. Number 11 looks at urinary retention in women. The whole article, this whole section kind of focused on urinary retention in men, but number 11 looks at urinary retention in women. 27 women. How long do you think it took them to collect 27 women with urinary retention? 7 years. This is not a common problem. This is, but they bring out a couple points. They say that in about 30% of them it was psychosomatic. Okay. But in 20% of them, there was either a spinal lesion or an infectious process. In 11%, they had unsuspected diabetes. And what they bring up a very good point, which is, if a woman shows up with urinary retention, and we had one about 2 months ago, it's that that should be a red flag. That before you go blowing these people off as being psychosomatic, you better look real long and real hard to make sure there's something not going on there. And this woman turned out to have what you would expect. She had multiple sclerosis. It was the first presentation of her multiple sclerosis. So a woman who shows up with acute urinary retention, it's got to be a red flag. They're getting either admitted or big-time consulted before they get out of the department. Let somebody else hang the psychosomatic tag on them, but there's a little bit too many bad things that can go on with these folks for us to just blow them off. And number 12, which is the final one in this chapter. Like I said, this is a very short chapter, so we can kind of blow through it and stay on time. This is one of those studies that I absolutely despise. Absolutely. This is a retrospective look, 285 patients who had catheters placed. I'll tell you what the data showed, and then I'll tell you what my concerns are with it. 36% of the people over the age of 65 got a Foley catheter, and they decided that only 46% of these people had appropriate indications. 35% had no indications and no physician order. They couldn't find a physician order on the chart. And so they determined that the vast majority of Foley catheters are placed in people inappropriately for no reason and without a physician's order. Now, here's the problem with it, and this is why I despise this type of study. Number one, depending on who you're trying to hang, it's very easy. If you do this study in the emergency department, you can come back and say, therefore, emergency physicians don't know what to do with Foley catheters. What they never look at in this kind of study is, you didn't want the catheter, you didn't order it, but the person who was admitted the patient said, hey, do me a favor, would you throw a Foley catheter in that patient? Sure, no problem, we're not going to fight about that. So you're tagged with doing this unnecessary test, but you're really doing it just for somebody else. So they never make that distinction. Number two, when you look at something like a Foley catheter, there's not a whole lot of documentation as to why you did it. If you're putting a transvenous pacemaker in somebody, you document why you're putting it in. The patient had, complete heart block, they were hypotensive, therefore I floated a pacemaker in them. If you're putting a Foley catheter in, there's not a lot of documentation we do about that. And a lot of these catheters are placed, they said there's no physician order on it. How many people always write down place Foley catheter? How many people the nurse just says, hey Al, can I put a Foley in this lady? And you go, yeah, as you're running off to see somebody else. That's the way most of our catheters are put in. So the fact that there's no physician order for the catheter doesn't really mean that a physician didn't give the order for it. It's not like there's these lunatic nurses running around who invest it in the Foley company and they want to put these catheters into people. And the final thing is they couldn't find an indication for it. An indication for a Foley catheter is something, number one, nobody documented. The nurse didn't write, was incontinent 5 times, therefore I asked for a Foley catheter. In the course of the emergency department treatment, what happens? Somebody says, Al, this person's been incontinent 3 times. Can I put a Foley in? Yep, you can put the Foley in. No documentation of it, but there was a clear-cut indication for it. And the one place where we put catheters in and it's never going to show up and these people never picked it up, and this is where I think they really missed the boat, is how many people take someone who is a little bit overweight, they're say, a little bit fluid overloaded, and you decide that you're going to diurese them in the emergency department. So you go ahead and you give them whatever your favorite diuretic is, and now it's a female patient who's up and down on the bedpan 5 or 6 times. And each time they get on the bedpan, they get more short of breath, and you say, you know what, you're perfectly continent, you have no neurologic deficits, there's absolutely no reason to put a catheter in you except for the fact that as a matter of convenience, it would be very nice for the nurse because they wouldn't have to keep running back. It would be very nice for you instead of lifting you up and down on this bedpan every 5 minutes, and you'll probably get better a whole lot quicker. The bottom line is when you look at this paper, this is one of those papers that just sets out to make us look bad and actually has no practicality when you look at how we actually clinically practice medicine. So, yeah. Don't put, and you were putting all the catheters? You're the reason? No. Oh. Oh, really? Uh-huh. All right. Any nurses going to fight with her? No. I wouldn't doubt it. If they did this study at our institution, would be exactly the results they would find. They would absolutely say, none of the doctors ordered any Foley catheters. None of us wrote an order for it. None of us wrote an indication for it. And you know what? I think it's not a bad thing in the emergency department not to have a nurse tied up, having to jack somebody up, put a bedpan under them. And my whole goal is never to be the closest one to the bedside when that woman asks for the bedpan. I mean, you got to look around. Oh, shoot. All right, I'll put you on it. And let's put it this way. I don't have to change the sheets. And my success rate on hitting the bedpan and getting it under them, probably about 50%. So, all right.